Hi guys, it's Tim from In the Mess. Today I'm going to talk to you about hip fractures. By hip fracture, I mean neck of femur fractures, not say pubic ramus fractures or femoral shaft fractures. They're slightly different, and I'm also going to focus in on hip fractures in the slightly frailer elderly population. Hip fractures can happen in young people, but they tend to take quite significant trauma, so we'll cover them another time. So the first thing I'd like to say about hip fractures is they are really common. In Scotland, there's about 6,000 per year. They tend to occur in the elderly, frailer population, and they are more common in women, as osteoporosis is more common in women. The second thing I'd like to say about hip fractures is the patients who are admitted with hip fractures are, for the most part, exactly the same population as those admitted to geriatrics with a fall. It's just that they've broken something. So therefore, they need exactly the same level of medical care that they would get on a geriatric ward, on an orthopedic ward. So let's start by talking about the clinically relevant anatomy when it comes to hip fractures. The neck of the femur, just like in the neck of the body, sits below the head, doesn't it? So it's between the head of the femur and the shaft of the femur. Now, we probably need to talk a little bit about the hip capsule, because this is really key in this area. Proximally, the hip capsule attaches to the acetabulum, and distally, it attaches to the neck of the femur along something called the intertrochanteric line. Now, you might wonder why I'm getting so excited about the capsule. Now, the capsule is how the blood supply gets to the head of the femur. So the key word you need to mention is retrograde. The blood supply travels in the retinacular arteries. These originate from the medial and lateral circumflex femoral arteries, which themselves originate from the profunda femoris artery. Now, they travel from the intertrochanteric line proximally towards the head of the femur. This is really important when we're thinking about hip fractures, as if you have a fracture that's inside the hip capsule, it means that the blood supply is disrupted to the femoral head. So if the hip fracture is further distal from that intertrochanteric line, the blood supply, it's fine, it's preserved. We don't need to think about it when we're planning how to fix these fractures. So when we're thinking about classifying hip fractures, it's broadly intracapsular versus extracapsular. Intracapsular, blood supply is disrupted, can lead to a vascular necrosis of the femoral head. Extracapsular, blood supply is fine, don't need to think about it. Assessment of neck of femur fracture patients usually starts in ED. Now, just like any other injury or any other presenting complaint, it's a full history and examination. That's going to tell you all you need to know. Most of the time in hip fracture patients, they occur because the patient has fallen over. It's really important to check they didn't injure anything else. You can get really distracted by a hip fracture and think, oh, it's just a hip fracture. Did they bump their head? Do they have a subdural hemorrhage? Make sure you've checked them over from top to bottom. In taking the history, look for reasons why they might have fallen over. Have they got sepsis? Have they got a delirium for some other cause? Have they started a new drug? Treatment needs to be initiated before you start thinking about surgical management. From a past medical and social history point of view, often these patients can be quite complex. It's important to make sure you go through them with a fine-tooth comb, but for me as an orthopedic surgeon, I have a specific set of things that I really want to know about. For me, my surgical intervention is going to be guided by what the patient is like. So, are they a senior citizen cycling champion that happens to have fallen off their bike? Or are they a frail nursing home resident with vascular dementia who mobilises only bed to chair with a Zimmer frame? That, for me, is what is most important to find out from the get-go. I also want to get them to theatre, so it's important to check whether they're on any anticoagulants or whether there's anything else that may need checking prior to them going to theatre, say a pacemaker. Capacity assessment is really important as well. Are they at their baseline cognition, or is something knocking them off here? We also need to make sure that their next of kin and family know that they're in.